It's fantastic to have Associate Professor Gabrielle O'Kane to address us for our final speaker. Lucky Gabrielle, has just retired as the CEO of the National Rural Health Alliance, which is a very large and very influential alliance of over 40, I think, national health organisations based in Canberra. But we've also been able to convince Gabrielle to become a board member of Western Alliance, which is fantastic to have her on board. Gabrielle, as I say, is the former CEO of the National Rural Health Alliance. She's an adjunct associate professor at the University of Canberra and also Charles Sturt University. She has extensive experience in the private and public health sector, which has contributed to her deep understanding of the needs for collaborative partnerships to support the rural health workforce and achieve positive health outcomes for rural communities. So I'll hand over to Gabrielle now, and she's going to talk to us about a rural clinician's journey into the world of research and where it led. Well done. Thank you. Thank you.
Thank you very much, Warren, and thank you for inviting me to speak here today, even though I'm in retirement mode. So for the end of the day, this is going to be a bit of a reflective piece about my journey, but hopefully it's helpful for some of you that are perhaps newer to the path of research. I just want to begin by acknowledging the traditional custodians of the land on which we meet today, the Jabwarong people, I think I might be pronouncing that incorrectly, and recognise their continuing connections to lands, waters and communities. And I pay my respects to elders past, present and emerging. So this story of my first foray into research was when I was working at Community Health with another girl, Karen Gard, and I decided that we thought it'd be a really good idea to apply for this $5,000 of funding back in the 1990s to do a research project in Gundagai and Temora looking at nutritional status of different groups of elderly people that were living in either in their own home, in a hostel or a residential aged care facility. And really, the aim of the whole idea was just to assess their nutritional status. The results of this study were not terribly startling because we didn't get many people involved. And also, when we first sent this off to the Nutrition and Dietetics Journal, there was a great big fat rejection. And I was kind of incensed by this, being so completely naive about the whole thing. Of course, what did I do? I rang up the Nutrition and Dietetics Journal through the Dietitians Association. I said, look, hang on, we're just a couple of rural clinicians that are trying to do a bit of research, so we need a bit of help. And so I think it was the deputy editor got back to me and said, I'll help you rewrite the paper. So we got it published in the end. So being naive, really green, was actually very helpful in these circumstances. So then when it came to my next move into doing some further research, I was working in private practice in Wagga, and I found out that nutrition and dietetics was starting at Charles Sturt University. So I thought, oh, this would be interesting to apply for that job. I didn't even have a master's degree at that point, let alone a PhD. But nonetheless, I did ring up and spoke to the dean of the faculty because he'd been one of my clients in the private practice. So this was a good mechanism by which I could approach the whole topic. So he said, yeah, look, I'll get the head of school to come and see you. So he came and saw me in my private practice and convinced me to come and work for them. And then I said, but hang on, I haven't even got a master's degree, for goodness sake. And they said, apply next week. So that's what I did. I applied through University of New South Wales to start my Master of Public Health. So from there, I actually did a project on rural men's health there. I beg your pardon, I should actually talk first about... this was perhaps, I'm just trying to think exactly when this was, but it was somewhere in amongst these first few years of being at Charles Sturt University, and I was approached by this dietitian who was working in the More Allied Health Services program. I don't know whether any of you are old enough to even remember that, but she rang me and said, look, she had been collecting some data about patients that had diabetes, and she and the diabetes educator had been working with this group of people, and she wanted to do some analysis. So this was a really good opportunity because I had students doing projects that needed some data. So they actually went out and collected the data, tidied up some of the data as well, because there were some missing bits and pieces, of course. And so, again, we got that one published in the Nutrition and Dietetics Journal. And again, there were small numbers, but it did actually prove to be quite useful. And the students were able to present at a couple of conferences over that one as well. So well worth joining forces, I would say, with clinicians in the area, or vice versa. If you're at a university, get on to some clinicians. This is the Riverina Men study. This is the one that was part of my Master of Public Health. Again, so this was a small project, like it was a 6-point credit point unit that was part of my Master of Public Health. And I chose a mixed method study, so I did some focus groups to start with, and then I followed it up with a survey. I did ask my supervisors, isn't just 4 focus groups enough for this particular subject? And they said, oh, no, you need to go on and do the survey. Thanks very much. So then we did do that survey, but what I actually learnt about some of that was they were in Sydney and I was down in Wagga. Not having that face-to-face contact was a real disadvantage in my view. So I learnt that when I went on to do my PhD that I needed to have some supervisors that were local. But I also did actually find out as well, they said, look, find some people at Charles Sturt University in Wagga that might have a really good understanding of survey work and that sort of thing. I realised that I went and got that, tried to get that help, but they didn't give me all the information because they didn't have a vested interest in my project. So I hadn't learnt about the Dillman method, hence we only got a 27% uptake of the... Someone's trying to ring in. Can I kill that? Yeah, they've gone. Whoops. I didn't think it was that interesting to the outside world, but anyway. So yes, they didn't tell me anything about the Dillman method, where I should have actually sent out all these reminders, and I might have got a lot more than a 27%. But nonetheless, I did get 3 papers published out of that, so I was pretty happy. I got my focus group ones and 2 others. I did a specifics farmers survey as well, which was good. Okay. What I then did when it came to my PhD studies, I thought that I really wanted to try and marry up, I guess, my experience as being a dietitian as well as being part of a rural lifestyle. I was married to a farmer and that sort of thing. So what were the sorts of things that I really wanted to do, and how can I blend those ideas? And I'm going to just read a little excerpt out of my introduction to my PhD. And I think it's useful for those people who are trying to think about how can I be an authentic researcher, and how can I maintain my interest in the work that I'm doing. And I think it's got to really be part of who you are. So my role as a dietitian had been to help people navigate their way through the maze of our food system, and I conscientiously did so. However, I was never confident that working in this capacity would yield positive results. I felt powerless to set a positive agenda for food and nutrition and push back the overwhelming force of the food marketers that promoted highly processed, energy-dense and nutrient-poor food products. The principles of the Ottawa Charter and the approaches of the new public health had been added to my toolkit along the way, but from my observations in practice and in life, the rise in obesity and other diet-related diseases continued unabated. My voice and that of my colleagues in public health nutrition had been muffled by the cacophony of big food. In parallel with the food system problems that I'd identified for consumers' health were the challenges being faced by farmers who needed to be more competitive to survive. To achieve this goal, farmers had to increase production and buy more land to benefit from the economies of scale. In Australia, dealing with impending drought is ever present, although some of us might wonder at the moment how that could possibly be. And southwest Australia experienced a severe drought in the first decade of the 21st century, which further affected the viability of farming enterprises. My husband and I were among those who had to turn to off-farm income to supplement our income, even in our early days at the family farm, and eventually left commercial farming altogether. We were simply not big enough to weather further setbacks from poor prices and climatic conditions. As a city girl who had gone to live in the country, I remember feeling frustrated and angry, reading letters to the Sydney Morning Herald penned by city folk who labelled all farmers as whingers for not quietly coping with the drought. Some would pontificate about the marginal lands that were being expected to support agriculture when, under good climatic conditions, these districts produced generously. I had grown to love my farming community, whose resilience under extreme pressure was nothing short of inspiring, and it still is the case. It was from this vantage point, as a community nutritionist and dietitian and partner in a farming enterprise, that I began to reflect more on the way in which the general public understood the food system. I wondered if they were in complete awe of the food that was available in Australia, or whether they scarcely thought about it. Food had become ubiquitous, so perhaps it was taken too much for granted. I asked myself if benefits for both individual and planetary health would flow if people valued food more highly and felt connected to the food system, especially those who grow our food. Was it possible to change the focus of nutrition and dietetics practice away from helping people to select food wisely from our complex food system to one that focused on creating an environment where people could deeply appreciate food? Fischler argues that people's relationship to food is a complex one, with a multidimensional character that is too often ignored by researchers. I did not want to be amongst them. So that was just part of my introduction, and I hope it sends that message about the importance of thinking about your own experiences, and you'll all have your own story about where you've come from and how you're going to go forward. But it really had a huge impact on the sorts of work that I did for my PhD, which is the movable feast. So you can see a couple of those papers up there. But also what I tried to do is make the most of students that were doing nutrition and dietetics as well. And one of those is this one down here, the contribution of farmers' markets to a more socially sustainable food system. And that student used a bit of ethnography, but of course it was a very short little piece that she did, so we called it an ethnographic snapshot, and that got us across the line to get the paper published. There was another one that we did with students that looked at the cost of food, comparing the cost of food in places in Canberra, and it took us 5 different journals to get that paper published. But something I've learned about myself, I'm persistent. So what does it all mean for you? And I suppose for all of you, I want you to think about the ideas of being curious as a clinician and explore some of those novel research questions that I'm sure many of you have. I think it's absolutely critical to find yourself a mentor that's going to encourage you and link you to the right people that are experienced. Be prepared for sometimes harsh and very bruising feedback, but I want you to keep pressing on. And I don't know, I had times when I'd be berating these people. How could they possibly be thinking it's so dreadful? And then you just have to rewrite and keep moving on. And I also thought it was so important to make every post a winner. So if you do have students, don't just let things fall away. Think about how you're actually going to get that to publication. I think it's important to choose topics that give you joy. And my PhD, I never got tired of my PhD, and I think it's really good if you don't get tired of your topic. So it's got to give you joy. I think it's also important, though, because I'm going back to what Warren said earlier this morning and thinking about the strategic directions of the Western Alliance. You do actually have to make sure you nail that part of it as well. You can't just move on your own little ideas because you won't get any money for that. I think you also need to take into account your learning style when you're engaging in research. I found that I really like to talk things through. Other people have different ways of doing that, but I think about how your learning style as well. I learned this from someone that taught us about doing writing with your PhD, but learn to articulate your research topic as though you're talking to a 9-year-old. Or sometimes the people talk about the elevator pitch, and I think those things are really useful as well. And if you have trouble getting things on paper, you've got to just keep writing, because the clarity comes when you keep writing. It doesn't come by just reading another paper. I'm sure some of you will know what I'm talking about. So how did I use some of that research kind of understanding when it came to the National Rural Health Alliance to inform some of the work that we've been trying to do? What I learnt, because I learnt an awful lot at the National Rural Health Alliance from the Director of Policy, who'd been writing policy for many, many years, but she didn't seem to have any reference at the end of every sentence, like she's supposed to in evidence-based practice. That's what we want to see. Anyway, I had to learn that there's a new way of doing this. So what did I do? I went to the literature. And that's exactly where I found where it talks about evidence-informed policy making as opposed to the whole idea of, evidence-based practice that we might know about. So the definition being, evidence-informed decision-making refers to the best available evidence and excluding spurious information, all in the context of other political and institutional features. And of course, funding realities are all part of that. So yes, you do have to make sure we're thinking about it's inexact sort of science based on reasoned arguments, but it's also about what the stakeholders are saying and what are the politicians saying as well. Our case for better healthcare, this is one of the infographics from the National Rural Health Alliance. It's based on data that's come from the AIHW and the ABS, but we've actually just put it in a format that's digestible for people. When it came to then we were looking at solutions for these barriers to attracting and retaining the rural health workforce, and we divided them into these 3 ideas of professional, financial and social. I won't go into detail about that. These are some of the sorts of papers that were out there talking about the evidence for barriers as well as enablers for rural practice. I think one of the interesting ones were the Mole-Mandel paper from La Trobe in 2021. It drew on a report from the RACGP from 2020, which was a survey of GPs. And something that I should actually add is that most of the sort of research in this area about barriers and enablers, it's all based on medicine, most of it. Not very much in allied health and not very much in nursing either. But this report was based on about 1,800 respondents. And what was interesting was that there was, of the people, the GPs that owned their practice, 50% of them said that they were going to be retiring within the next 10 years. That's really alarming, like you've got to think about that. And then the other thing was that of those GPs that didn't own a practice, 60% of them said that they have no intention of ever owning a practice because they just don't want the responsibility of it. They want a bit of work-life balance. They know what the people that own the practice, how much work they're doing. They don't want to do all of that. That was important in thinking some of these things through. The Holloway paper talked a lot more about the social impacts that, like the spouse, partners, the children, educational opportunities, jobs for their partners, etc., that sort of thing. And then we've got Kath Cosgraves in the room here at the moment, and she spoke again about her retention model, I suppose we would say, and talking about how the sense of place and people's connection to community and how important that is for retention in rural areas. But career pathways are also terribly important, but also feeling comfortable and happy and supported in the workplace as well. So this brings us to, this is the final slide, just talking about the principles of the Rural Area Community Controlled Health Organisations, which is based on the ARCHO model, which many of you would be familiar with. There is this, at the moment, there's a move away from using the word RACHO because it is seen to be potentially confusing. So we might be looking at another way of speaking about rural area community controlled health organisations. So if you've got a really snappy idea, please get in touch. We've gone over that a million times, and we used to call it place-based health and wellbeing networks, or PBHNs, and of course everybody glazed over. But when you started talking about RACHOs, people knew exactly what we were talking about. So the principles behind the rural area community controlled health organisations is about having a place-based model of care in recognition that no two rural communities are the same, and that they needed to be flexibility because of the jurisdictions. I should say that Victoria is much better set up for community health and primary care than they are in other states around Australia. Certainly looking at the idea of funding, having block funding, but supplemented by MBS items, NDIS, etc., not just based on the block funding, because that often just stays the same over a long period of time. But importantly, making it an employment model. So employment for all of the health professionals across the multidisciplinary team. There's some, and again, this can be flexible because there's some talk about maybe the GPs having partly MBS items directly paid to them and partly a base salary as well. So there's all sorts of ways that you can be flexible about that. But then, because that has to really acknowledge as well that whole employment model is really to make sure it's attractive because of the thin markets, and it's really some allied health professionals perhaps in private practice here today may know how difficult it is to make a living by being in private practice in a rural area, because you just don't have the critical mass of people to be able to make money. And GPs find it difficult as well. And if they're in smaller practices, they don't always know what sort of items, MBS items that they can bill for, etc. Local governance for both clinical governance, but also for business governance is also really important too. So they're the principles. And look, in the October budget, there was $24 million set aside for innovative models of care. So I'm still hoping, and I know I've retired, but I am still hoping that $24 million goes to the Alliance. So thank you.